Right. Tim's just described to you the need that people have. But actually, people don't think about themselves in terms of need. They think about themselves as what do they want and what care do they want. And they want stuff that's right for them, as you can see from the slide that's up there. But remember that people are all different. And when we talk about the word integrated care, integration means different things to different people. To a young man with a bad knee, he wants to know that when he tips up in the hospital, they've actually got the X-ray in front of them. But to somebody like a GP, we want to know that we've got the letter in front of them. But another form of integration for other people is an elderly person dying at home. They would really like to know that anyone who visits them, whether it's social care or a hospice service or GPs or a nurse or whatever, knows what their wishes were about where they wanted to die and how they wanted to die. So we moved on from the need to what's going to give people the right service for what they're doing. So we said a one-size-fits-all isn't really good enough. That gets too top-down, and general practice, we know we have chips on our shoulders about top-downism, and smiling at me, but we also feel that we actually have a much better idea of what's not going right or what our patients actually need. So we started to look at the fact that if you talk to patients, if you talk to the chattering classes, they'll tell you that they want to see a GP at 9 o'clock in the evening and be able to have their physio appointment the next day. So they're the young, fit, healthy people who want a fairly instant service. They don't really mind who they see, provided they're competent, and they want to be in and out and sorted and dealt with. But then you talk to the elderly patients and people with long-term conditions, and they actually want to see the same person. They want to have enough time not to feel rushed, have time to get undressed, get onto a couch and things like that. They even really appreciate whoever they're seeing actually knows that their cat died last week, because that's actually something that's really important to them that matters. Taking adults with specialist care, next one's down, they want to know that when they need the really fancy tertiary care, they can get it, but that they don't always have to go all the way into centre of town to get it, that some of it can actually be done locally, and can we make that join up in that sense for them. And some of that group actually, it's not medical care they need, it's social care. It's getting the housing right. And how do you find how to talk to the boroughs and the housing officers so that you can actually move somebody into the right sort of housing for them? It goes back to the TB, for example. We know that a lot of those people default from care because you haven't given them the right housing. And then take kids, which we aren't talking about that much on this because our population segmentation, we aren't actually looking at children. But I'm also sitting on some of the London children stuff that's going on, who are feeling that children are often being marginalised. But here, it's not just parental education and support. They go to school. Has the school's got what they need? They've got specialist care in town, but they again would like outreach stuff locally. They've got siblings. They've got a family life. And if make things right for people, we have to join it all up in that sense. So the next slide is not a slide, it's a video. And if I press this button, hopefully.
Ten years ago, I was a very successful television executive, but once an illness gets you, particularly cancer, you have to be very strong. I think people who know me recently would say that the cancer, the second time, really knocked me sideways. I find it very hard coping, particularly also this obvious, what the doctors say is diabetes. I think that integrated care, to me, means that all of these people are talking to one another. They know what you need. If you suddenly have a deterioration or you are suddenly very ill, more people will kick in than used to. They know immediately what I'm allergic to, what pills I'm on, if I'm unconscious and they can't find anything in my handbag, who my GP is, what surgery I've had, and that is developing, that's getting better.
I've got diabetes type 2, and the reason that I've recently had bariatric surgery is to help control my diabetes because it was getting out of control. My GP rang me up with some results and everything from my blood test, and we were discussing them, and he said that my controls weren't very good. He asked my permission to go to a board of diabetic consultants and discuss my case. So yes, they are communicating, and they are communicating, if you like, behind your back, but they do talk to me as well. My GP's been very good that way. It's reassurance for me. I want to know that he knows what his left arm's doing, them all communicating has given me more confidence. So I'm not so frightened when I go to the doctors now, because I know that they'll talk to me, and if I do have any issues, they're going to listen. Whereas before, I didn't always have that. But I'm a lot happier now, and I am more confident now.
So that was two patients' points of view, and though those were studies that we actually set up and went out across North West London to talk to patients and find out. This is now a much busier slide. We then decided that somehow or other you can take the top-down bit, but you've got to sort of divide it up so it's in manageable pieces. We picked up a lot of the research across the country, and then we took a group of people for brainstorming about what makes people fit into categories. Now, be careful, because people don't really fit into categories, but if you take it in the round from a top-down point of view, they do fit into sort of categories. So we took, there must have been about 30 of us for felt like about 3 hours. So it was GPs, social workers, patients, hospital consultants, tertiary hospital consultants, lots of people from the local boroughs, mental health teams. So we took the gamut of people from mental health, social care and medical care. And we said, if you were going to divide people up into some groups, what are the natural groups? So we spent ages with Post-its putting them all up, and then we shuffled all the Post-its around, and we came up with, roughly speaking, these sort of groups. And then in parallel with that, so we didn't do one first and then following the other, we sent some people off, and actually Philip described it very well. I would have just we sent off the people to do some data statistical regression-y, something or other-y stuff with all the figures that we have, because we had all the primary care data, all the social care data for Hammersmith and Fulham, which Tim alluded to, secondary care data and tertiary care data. So put it all into their social, statistical, whatever it was, and said to that, how does this sort of chunk out into sort of meaningful groups? And it was really interesting, because the soft, fluffy way, which we did it just as people talking, and the way the statistics did it, actually came up with very much the same groups. So these were the groups we came up with. And as you can see, the top line says, we said we were not going to focus on integrated care for children at this point in time. And I think it really is that point in time. We've had some feedback about this slide showing the groups we've divided into, and I'm not going to read them all out to you because you can all read, about people felt that meant that all you did with an elderly person with cancer is look after their cancer. That's not true. Or any of these people, if they have a sore throat, a rash, break a leg or whatever, they will still get all the core care. It's just that what makes them special in the population, or what puts them into a group with other people who are fairly similar, is the bit that we were dividing up. So don't feel that they don't get everything. They get everything anyway. This is the slide which has come out of all the number crunching, and I'm not going to say too much about that one. I'll explain it to you just so you understand what it is. The blues, this is Hammersmith and Fulham CCG for a year, because they were the only CCG that collected the social care data. So the blue circles, the little blue circles, these circles, is the cost of a patient in that group for the year. So you can see that our basically fit and healthy people only costs about £800 a year. But of course, if somebody has a big road traffic accident, they will actually belong to that group, and they'll cost an arm and a leg that year. And you can see that people with a learning disability, all right, yeah, it was an accident. People with a learning disability, roughly speaking, whatever their age is, cost you about £50,000 a year. The little blue boxes tell you the number of people in those cohorts. So you've got 120,000 in that cohort, but actually in the over 75 learning disability people for Hammersmith and Fulham that year, there were only 23 people. So just to give you sort of spacing it out. And then the light blue boxes, light grey boxes, this is the amount that group costs you in millions per annum. So £90 million to look after your mostly healthy, and £1.3 million to look after your 23 over 75 patients with learning disability. So these last two slides have definitely been top-down variety of slides. So the next slide is what the group of us who all spent time brainstorming over about 3 sessions said. We said, well, it's all very well, this top-down stuff, but there's all this other stuff that you haven't taken into account, and it actually matters when you're trying to get care to work for a patient at home in the community. And what are you going to do about that? And that is actually a problem, because some of it you can number crunch. You can probably put the deprivation in eventually. But things like behaviour, people who are happy to go off to a self-education group and actually learn how to look after themselves. But then there are other people who they'll just never do that and bounce around the system, hurting themselves and perhaps hurting the finances as well, because they won't do that. But you have to allow for that, because that's how people are, and you're not going to change their spots very much. So we're very much aware of this group, this lens, as we called it, which you have to look at anybody who's got diabetes or whatever. And, you know, if they're diabetic and frail, they're different from if they're a feisty diabetic aged 80. So as I say, some can be counted and some can't be counted. And I think most of this lot is actually going to be looked after by the carers who go in. Your unpaid carers, your ordinary carers, your district nurse who bothers to do something else extra. I don't see how we help keep these people integrated unless you do that. So I suppose in summary, and it's come over quite clearly, to get it right, you have to toggle from the top, which is how you have to work out finances and make things work. But if you don't get the bottom nitty-picky bit right with the actual patient in front of you, we still won't end up with integrated care.